when you use any sort of levodopa product, the principles that you have to keep in mind is that it needs to get in the brain to work. If it doesn't get in there, it's not going to work, okay? And the other thing is that you have to block the conversion in the body to prevent side effects. If you don't block it, you're just going to throw up and you're going to have all kinds of side effects, okay? So just keep those two principles in mind, okay?
Well, how do we know it's getting to the brain? Or how do we take it so it does get to the brain?
Okay, and so that's what I'm going to go through now, okay? And so okay, and so this is graphically kind of showing to you, if you just lose levodopa by itself, the majority of it goes out into your gut and into your blood, and very little gets in the brain, okay? That's why levodopa is not used by itself. It's always used with something else, like carbidopa. That's the reason why you have to do it together. The carbidopa blocks the conversion into dopamine in the body, and so by doing that, it allows more of it to get in the brain and less of it to go into the body and to have fewer side effects, okay? Okay, so now we look at the different products we have for carbidopa, levodopa. I just underline the medications with the 1-to-4 ratio because that has the highest ratio of carbidopa to levodopa, okay? And the reason why I emphasize that is that there's no downside to having more carbidopa. There's none. You might as well use more to block the side effects, okay? Of course, plenty of people do perfectly fine on the 10-100 or the 25-250. I'm not saying you can't use it, okay? I'm just saying if you want to block the side effects, use more carbidopa, okay? All right, okay. And then, just so you know, the controlled release form lasts longer than the regular, basically about double, okay? But the onset is kind of delayed. Some people don't like a controlled release because it doesn't work fast enough, okay? I know that, and so if you don't like it, don't use it. But I'm just telling you, there is a rationale behind using it because it does last longer, okay? And then the only other thing that keep in mind is that these duration of actions have to do with the clinical duration. The actual half-life in the bloodstream is only 45 minutes. I mean, after you take it, it goes up in the blood, but about 45 minutes, half of it is already gone. So in other words, it disappears very fast, okay? And so the question is that then, how can it last 6 hours then? It does. No, it does at the beginning, okay? Why does it do that at the beginning? No, because your brain stores it, that's why, okay? The brain stores it, okay? So that's why at the beginning, the carbidopa, you could just use it 2 or 3 times a day and then you're fine, you're happy, okay? 10 years later, it's only gonna last about 2 hours or 45 minutes or something like that. And so that's why you're gonna be taking it every 2 hours, okay? All right? Because at that point, further along the line, your brain is not able to store it as well as it used to because the degeneration still happens, okay? And so that's what happens, okay? And so anyway, just so you know, there is carbidopa or lodocin available commercially that you can add more carbidopa to help block side effects, okay? It's only available as a brand name, so it does get kind of expensive, but you can do that when you have a lot of nausea or other side effects from the levodopa. Okay, all right. Now, when the medications wear off and don't last long enough, it gets more complicated. And in that situation, going to see someone who's experienced is definitely going to be helpful, okay? Because whoever you see is going to have to spend the time to figure this out, the timing of the medications and all that sort of stuff, okay? I know that nowadays in this, a very highly regulated environment for medical care, the doctor may only see you for 15 minutes. And so how much of this can they do, okay? And so you got to keep that in mind. And so, but it does get very complicated over time. Okay, and this shows that the complications, by 10 years, on average, about 100% of the patients will have some of these complications, okay, after you've been on levodopa. Okay, this just shows what happens with the long duration effect of levodopa early on. They could last some 6 hours or so. Okay, but later on, it spikes up and it wears off really fast and may last less than 2 hours. Okay, it just graphically showing what happens over time. This just shows the dopamine in the brain, normal in the early Parkinson's and advanced Parkinson's. You see that the signal decreases over time. Okay. Okay, and then graphically showing the same thing. Early in disease, it's easy to stay in the green spot, but as disease progresses, you get into the red zone, or where we have poor control, it's more prone to either you can overshoot or undershoot and be moving too much or moving too little. Okay. Okay. So when you have the motor complication, you can adjust the dosing and the timing of the medications. Okay, and so graphically again, you can treat the dyskinesia by decreasing the dose of medications so it doesn't peak as high. Okay, and then you could also add a second dose or add another dose when the medications wear off. Okay, you can also add medication to help prolong the levodopa response. Okay, and then in this case, this goes more toward some of what was brought up earlier, is that levodopa can be prolonged by blocking the enzymes. There's a carbidopa that we all know of, and then there's also entacapone or Slevo, which will block that as well and increase the amount of levodopa that's around, so you have a longer effect or a bigger effect. Okay?
Can you explain Azolet?
What?
Azolet.
Yeah, and so if you just a little further, and then when you get over there, you can block other enzymes that break down dopamine, and in this case, the MAOB as well as COMT break down dopamine. Azilect or rasagiline or Selegine blocks the MAOB, and that allows more dopamine to stay in the brain to have its effect. And you could also use tocopherol, which has an effect on the brain. Entacapone or Comtan has more of an effect outside the brain. Okay. And dopamine agonists, if you use them, they skip all of this and just act directly on the nervous system. Okay? Okay. And so the other thing that can be done besides the adjustment of the medications, you can try to prevent these from happening, and that's the logic behind using the agonists early. Okay? And so you may have seen these figures. If you, instead of using levodopa at the beginning, you could use an agonist, and if you do that, then you could prevent some of the symptoms, okay? And these studies were all done in about 5-year time span in terms of reducing some of the complications, okay? The thing that we have to keep in mind is that what has happened since then is that we've now looked at some of these 15-year studies, and in the end, it shows that after 15 years, what medication you start really doesn't matter, okay? So in other words, between you and your doctor, you figure out what helps you the best at the time. We can do all these fancy things about planning for the future, but things are turning out to be a wash in the end. And so what I'm saying is that I try to be very practical about this. If you cannot do something, let's try to fix it right there. And let's not worry about some of the things in the future. We can plan for some of them, especially if you're young, okay? Because we have to plan for a lot. But overall, we still got to get you functional and doing well and having a good quality of life. Okay? Yes?
My question, excuse me, is this. Are you better off going as long as you can without the medications and going on to medications right away? If you're not doing that bad and you feel comfortable with the way you are, should you try medications or should you just stay away until you absolutely need them?
Okay. That's a question that we've asked for decades now. It's always been the same question that's become. Back when we used to think that levodopa might be toxic, okay? Because of that, we used to hold off on it for as long as you can, okay? And so then we did the L-DOPA study, and basically that study showed that it doesn't look toxic at all. And so in other words, now we have in cell cultures, in animals, and now people, there is no sign of toxicity whatsoever, okay? And so in other words, what I'm saying is that there is no evidence that saving that is going to help you any more than using it. So I would say is that, you can make that argument, but the problem is there's no proof, okay? And so you can do that, but you don't have to because there's no proof, okay? And so what I would say is that let's go use the medications to help you. And if you need it, let's use it. If you don't need it, then you don't have to use it.
If you feel good without it?
Yeah, don't take it.
Then feel good.
Yeah.
If you feel good with it, then feel good.
Yeah, I was just thinking, like, instead of all this pill form, why don't they do it in injection form? Like if you have diabetes, you take insulin. Why don't they do dopamine in an injection?
Okay.
We may get there. I'm not sure tonight, but you might get into Apoquin.
Okay, I'll get that in a little bit. There are ways of doing that. Just so you know, levodopa cannot be injected, okay, because chemically it doesn't work, okay? And so there's other ways that I'm going to talk about in a little bit in terms of the delivery. So it has to go through the gut. Okay.
What was, a couple slides back, you had an agonist, where it had the 3 columns, and it started with an L. What was the name of that agonist? Couple slides, about 4 slides back. You had. I couldn't see it from here.
The agonist?
There, right there. What's that?
What agonist?
The yellow one.
Oh, that's levodopa.
That's levodopa.
Okay, it looks different from there.
Let's leave it over. That's all. Okay. And so let me go ahead and quickly try to finish a little bit before I get into trouble. Okay. And so we have a DBS, just so you know, and just so you know that deep brain stimulation is approved, and it's approved for patients who respond to levodopa. So you don't use the surgery for people who are any of the atypical or don't respond to medication. You don't use it. So in other words, when your medications don't work well enough and you're going up and down too much, then you can do surgery, okay? Just keep that in mind. So we have done the surgery in patients who don't respond to medicines, and they don't do very well at all, okay? It's just so you know, okay? So we don't do it in those situations, all right? Okay? And then if you have dementia, we don't use it because the DBS often makes dementia worse, and so you don't want to use that, okay? And so the last thing I want to give is that the new thing that's coming out is duodopa, and this is more toward like what you're talking about. Duodopa is a continuous infusion through a tube into your gut. Okay, so what it looks like is this. You put in a tube into your gut, and this way you have levodopa going there continuously. Okay, and so that way it works. You can't inject it though.
Okay, but that's a good way. I mean, people are doing that with diabetes now, having a little patch.
Yeah. Okay. Yes. Yeah. This is probably the closest thing that we have to that. And so the issue is that you're going to have a tube, and so you have to take care of that tube. That's the only thing, and it's going to be out in about the next year or two. And so just
Damage the brain quicker than the pill?
it wouldn't be a quicker. It just makes it even. It's not an issue of speed. It's just you just make it very even, so you don't have the ups and downs. Okay. So that's
We'll
it.
have an article in the next newsletter on this because it's actually something that came to us in about 19.
Time's up. Okay. Yeah.
It came to us in about 19, I don't know, 86, 96, something, a long time ago.
Yeah.
And we'll tell a story about a young man who was doing this on his own before it got into.
Yeah. That was very interesting when you get a story
So
before.
is this
Yeah.
the research that you're doing now, or is there new research that you're doing? Is there anything new in research that you're doing with Parkinson's?
Well, it depends upon, that's kind of, there's hundreds of different labs doing different things, and it's impossible for me to go through all of them. So when you say you're talking about me specifically,
No, like I know there's so many foundations, the Michael J. Fox Foundation. I mean, there's a lot of money coming in. So, I mean, what is the most, the wonderful thing that they're working on
Well,
right now?
I have not been able to introduce Dr. Song to something that I think is absolutely magnificent. We had an opportunity once and then somebody got sick and we didn't get there. But there is a company down in San Diego that is working on a science where they have been able to, in mouse models, target and destroy alpha-synuclein. You heard that word tonight. They've been able to target and destroy tau, which is another one of those proteins. They have been able to target and destroy a small LARC2 product. It is not as potent as the LARC2 that they need to buy, but they wanted to make sure that they could actually do that. And then the fourth one that they want to target and destroy is Parkin. And there is a point in time, we've been running this information in our newsletter for the last 2 years, called an update on the road to the cure. And I really want to take Dr. Song to meet these gentlemen, the main scientist in particular. It's a small startup laboratory, and there is a tremendous amount of money being raised for research. However, this particular company doesn't need a tremendous amount. And when I say that, you're gonna laugh at me when I say all they're looking for is 10 million. And that, in the scheme of things, that is absolutely nothing. But I have said this for a little while now, if they had $2 million tomorrow, they would be at human clinical trials in 12 to 18 months. Now, you may know somebody with $2 million, or you may know someone who has, in $100,000 increments, an opportunity to invest in something like this, which is investing in humanity. But I will take Dr. Song to meet them and to view this, because I think he too will be as excited as I have been for 2 years on it.
Okay.
I understand that the Technion in Israel is working on some of that.
This one is very different than Technion, but you know, a lot of people are working in a lot of areas, so we need to applaud them. But what we will see in the next newsletter is that you all in this room tonight are as smart as anybody out there working on this. But you just have to let go of those barriers to think that you're waiting for some scientist or some doctor to do this for you. You're the ones who have to get involved. You're the ones who have to do the conversation and have the conversation and understand what it is that you're looking for, how you think it'll affect you. You got a tremendous amount of information tonight on the proteins and the plaques that are involved in this. You've got some of the medicines that are involved in helping you get through it. Now take that information and be on this team that we're talking about, and let's go and get rid of this stuff for now and forever. And we can do that because we are smart enough to do that kind of thing. Follow me. No.
Let me conclude a little bit with just a couple of slides. That just shows that when we think about Parkinson's, that on average we have about between the time of death and how long they have Parkinson's for. You see here that consistently there's around 15 some years with Parkinson's, and so in other words, you're gonna live with the disease for a long time. Okay, so you're gonna have to be prepared for dealing with the issues for a long time. There's nothing that's going to happen suddenly at one point. Okay, of course, gradually over time, there's something major can happen along the lines because of complications. But on average, people in general live a long time, a good 15 some years after the diagnosis, and definitely before death. And so you do have to plan for the long term. Okay, and so that's part of the reason why I presented this as I did in terms of phases, because things get increasingly more complicated over time as time goes on, and so you just have to prepare yourself.
And so the key word there was planning. Thank you for saying that this time, because somebody in the last meeting said, "Why would you show this to us?" And it's just for that very purpose, so you can plan through the rest of your life, financially, family-wise, any other way.
Okay, and finally, the last part that I'm not going to get into too much because in a lot of ways the situation becomes very complicated in terms of what happens over the course of the last 5 to 10 years or so. Is that we'll get to a phase where a lot of the non-motor complications is that other issues besides walking and moving and tremor and stuff, they become such a big factor in what you have to treat that you got to find other ways to help it. And so that's when the other things besides the medications have become very important. We have to use the therapies when we can, because so many of the other things are starting to happen. And so the medications, just so you know, they only help with movement. They don't really help with some of the other symptoms. And so when that happens, we have to use some other things. Besides the medication I mentioned, all those medications were for movement. And for the other problems that happen, you have to use other things. And so there are other categories of medications which we have less choices for, and we know less about, and we have to involve more other specialties and other therapists to treat the patient as a whole. Okay, okay, okay. So yes, go ahead.
Didn't mean to interrupt you. Is the controlled release levodopa carbidopa, is that in the form of a patch?
No, no. They've tried to make it a patch, but it just doesn't go through the skin very well. It doesn't work, and so there's no patch.
So it's just a different kind of a pill then?
Yeah, yeah. Okay, and there was another, yeah.
I was just wondering your opinion on transcranial direct current stimulation, especially as you're getting to middle and late cases.
Okay, I think that has hope for trying to treat the symptoms in advanced patients. I do have some research interest in that area, and I have some collaborations with people doing that. We're talking about a stimulation with either direct current into the brain or even the transmagnetic stimulation as well. And so those kind of treatments have shown to improve symptoms temporarily, okay? But the problem has been, how do you get the improvement to last longer? And so we're working on that. And so we have hope for the future in using those methodologies. Hopefully we'll get to a point that we can use them. And so that's a good way, without medications, to try to stimulate your brain so that it works more normally. And so hopefully we'll get there, okay?
So how many of you would like to have Dr. Song here in the desert? I am so grateful that he drove over the mountain to come and speak with you tonight, and thanks to his wife sitting back at the table there who came along.